Okay. Uh, Hi there, and welcome to our session, In It Together, Cultivating Resiliency in Care Teams Amidst Pandemic Stress. My name is Andrew Phillip. I'm a clinical health psychologist and the Senior Director of Clinical and Population Health here at the Primary Care Development Corporation, a national nonprofit based in New York. But our mission is really focused, and we've been around since the 90s, on enhancing health equity in meaningful ways. We do this through capital investment to the tune of over $1 billion in underserved and red light communities, through training and consultation around healthcare in over 40 states, and through advocacy at state and national levels, particularly around enhancing care for populations that are often disregarded or vulnerable and who need assistance most. So I'm honored to co-present today with someone I've learned a lot about rehab psych from as a trainee years ago, and now as a colleague. Deepa, I'll hand it over to you.
Yeah, so I'm Deepa Ramanathan Ellie, and I'm a rehabilitation neuropsychologist. I work for the Department of Defense in their Intrepid Spirit Centers, which are traumatic brain injury and psychological health clinics that are spread throughout the United States at military treatment facilities. So I'm located in Fort Belvoir, Virginia. And within the clinic, I have various responsibilities, clinical research responsibilities, but I also play a role in enhancing our interdisciplinary teamwork on our rehab team, and how to create a better culture and a better functioning team as well. So that relates to the topic and where it kind of came from, our topic today that we'll be discussing.
Great. All right, so here we go. And just a quick disclosure on my end, I have some interests in a technology company that builds resiliency and communities for clinicians, but I am not talking to talk about any of that today, and this really has no bearing there, but I'll certainly share any lessons I've learned along the way. But really, we have no vested interests or commercial interests in this presentation, and certainly this does not reflect the views of the Department of Defense or any aspect of government. So our objectives here, at the very highest level, we're going to try to talk about resiliency in a meaningful way that's sensitive to context and that can result in true change. So we're going to do that, getting us all on the same page about what resiliency is, at least how we're defining it. We're going to talk about what are the kind of core characteristics, and specifically when it comes to healthcare providers and rehab teams, how can we use this knowledge to really apply ourselves? And then finally, our hope is that you as attendees and really participants in this discussion will leave with some specific steps that you can employ today, tomorrow, into the future to really affect change yourselves. So I'm going to just briefly acknowledge the context. We all know that COVID-19 has been ravaging our country for about a year now, and of course, not only impacting the health of our patients and the general population, but ourselves. And I'm going to kind of pull a couple news items here. As someone who kind of focuses on national workforce, I'm deeply concerned, I think a lot of us are, about but a potential exodus of sort of exhausted, demoralized, and burned out professionals who are worried about the future. We're concerned about the mental health and well-being, and as well as physical health of healthcare providers. And about the compounding nature of exhaustion and burnout, spiritual and physical and emotional, that's been happening really for years now. And there's a tweet that I really appreciated from a physician back in September, Dr. Chung, and I'm just going to read her own words here because it's almost a call to action for us. She said, asking for increased resilience when faced with systemic barriers is trying to squeeze water from a stone. It unfairly places the blame on the individual who is not, quote, resilient enough, and adds to burnout. And she calls for compassion and change. So, we want to be honest. We're not trying to say, you get through this incredible moment we're in, and not only just pandemics of COVID, of racism, of incredible political strife and pain in many other ways. That's not necessarily something you just sort of cope through. So we're talking about applying resiliency at many levels and empowering us as psychologists in doing so. I'll just sort of mention briefly, when we're thinking about the current context, it's not just what's going on. It's not just the health provider shortages. It's just even normal stuff. Like, where do you go to relax? Where are you taking your lunch break compared to maybe where you did a year or two ago? What does the actual act of patient care look like? Are we still sort of contacting our patients physically? Are we sort of go-betweens with their family? And then even outside of our actual provision of care, life has changed, right? Our relationships and contact with our family, with our hobbies, with exercise, and all sorts of other things that normally help us thrive have dramatically changed. And all this is swirling around us. And again, so when we think about all these things coming together and sort of also the collective potential for trauma here, we're going to be talking about how this, how we have opportunities to impact this at the provider level, at the level of teams that we work with and our organizations. And really, and actually, I'm going to turn over to Deepa here to talk through how COVID is impacting this, but also what the downstream outcomes can be if we choose to make a difference.
Yeah, and so just this is just a visual depiction of what Andrew has already covered, just demonstrating, and this is adapted from the AMA, a figure from AMA, but just showing that COVID can impact the whole system of care, rehab and healthcare delivery at the organizational level, team level, and then the individual level. And then if you think about probably in a lot of these structures, we had pre-existing prior coping strategies, support resources, safety resources that were in place to help buffer the adversity of some stressors. So we had some probably preparation. But in the light of new stressors, there needs to be some more adaptation and flexible thinking. And if we don't have that and there's no adaptation, no intervention, then we ultimately have poor outcomes, chronic distress across the system, leading to poor patient outcome. But if we do have that adaptation and some interventions over time, it can lead to better coping, rest and recovery across the system so we can learn and adapt for future stressors moving forward. And so when we think about across the healthcare system, again, there are coping strategies that could be distinct and helpful at a provider level, at a team level, and an organizational level. And just very briefly, we've listed them out here. But when we think about these strategies, when we're coping with distress, there's a number of different strategies to facilitate wellness, to cope with very challenging work environments, and within the psychological literature, as well as the healthcare literature on human factors in work environments and organizations, those strategies are termed as resiliency strategies. And so I want to start by, first of all, talking about what resiliency is and then going into the strategies themselves. So here's just a great quote from Bonanno saying, resilience refers to a stable trajectory of mental health despite exposure to a serious stressor. And in the face of COVID-19, one needs to cope with ongoing stressors and manage to keep psychological distress at a minimum. Okay. So when we think about what are the factors that are inherent in this conceptualization of resiliency, one thing to just make note of as we go through some of these factors is that it's a dynamic process. So resiliency can change over time. You can have less resiliency in one context, more resiliency in another context, or that can change throughout a lifetime and throughout various situations. But some of the factors that are inherent to resiliency that we see throughout the literature is that, one, it has this awareness and insight factor in that we are aware that there's been a change. We know when to react or what coping strategies to use in various situations. There's also an aspect of self-regulation that we're able to, either the system or the individual is able to manage a variety of stressors or situations without significant impact or malfunction. So we're able to return to this homeostasis, which is probably what a lot of us think about when we think about resiliency, is that bouncing back. And then there's this integration portion where the lessons that we have learned from various stressors or situations in life, we're able to integrate those lessons, that new information, and move forward with some positive growth. And in order to do all of that, we need to have this adaptation, this ability to think flexibly, adjust expectations, whether that's on an individual level, adjusting behaviors and cognitions, or on a system, organizational, or team level as well, adjusting our procedures in order to manage a stressor. And so when we think about the conceptualization of resiliency as well, I think it's good to just make note of the fact that it is a really complex conceptualization. On a psychological level, we know it's a biopsychosocial conceptualization, so it can include personality factors, societal factors, environmental or interpersonal factors. And it's similar on a healthcare level as well when we talk about healthcare resiliency, but there's healthcare resiliency also, it's a proxy to safety and patient outcomes as well, which is a little bit different. So it talks about how is failure avoided, or how can you obtain successful outcomes in a really high risk, challenging situation, and how do people learn and adapt to create safety boundaries, to reduce hazards, to reduce risks, and optimize outcomes, and really reduce patient harm is the ultimate outcome for healthcare resiliency. And actually, I'm going to turn it over to Andrew to talk about who is actually in charge of doing all of this.
Yeah, thanks, Diva. So I think that that's sort of like who's responsible, and not only that, and who's accountable, but who's in a position to influence this. And surprise, surprise, we're going to be talking about you and a little bit of me. But like, who are those key players? Let's just call them out, right? There's all these external systems at play. There's payers, like managed care organizations, but also Medicare, Medicaid, like those big kind of governing bodies, policymakers, those who accredit us. But also our organizations, and I'm talking about like not just sort of those who are sort of in leadership levels, our managers, the physical constraints of our organization, sick time, leave time, all that, the care delivery, but also sort of our internal factors. And that's really what we're going to focus on here, that can sort of be these mediating variables that make for individual difference here. And so kind of thinking of what we know about that, right? So thinking of the sort of provider as us, our sort of convenience sample here. What do we notice about ourselves, and what do we know through treating others as providers that might help us sort of maintain some sense of control, or at least capitalize on resiliency at the individual level? I love this photo. Although it's sort of that like classic family medicine doc who does house calls. Frankly, it's a little bit before my time, but I think it's an image that we can all sort of relate to, regardless of our profession. It's that idea of this simpler time where the reason we all got into this, right, to provide care, to heal others, to heal communities, and to be part of that healing process, it looks a lot different now. This visiting family doc is now spending a lot of their time on the electronic medical record. I just actually polled a whole class of medical residents, and they said that was the number one thing that they're spending their time on right now, not patient care or anything else. So again, like I think of where resiliency comes into play is where there's something that's sort of inserting itself between our experience of meaning in healthcare as caring individuals, as healers, and the work that we're doing, and then the outcomes that we're experiencing as part of that. So when we talk about those individual factors, I get a lot of pushback from, I work with many physicians all over the country, and they're sort of like, do not tell me to breathe. That cannot be the answer to all this. And we love our deep breathing, but I'm going to sort of call it a couple interventions, but we're not going to sort of rest our hats on that necessarily. But I do want to just sort of acknowledge these things. So, I'm not going to go into these in much detail because I think we know about these, right? We know about internal mechanisms, things like relaxation strategies, including deep breathing, cue controls relaxation, or building rituals. Different from breathing, obviously, but mindfulness and sort of insight or awareness raising strategies, or as we've sort of changed them in healthcare into sort of practices, but meditation, contemplative and reflective practices. Even these sort of bundled interventions where we take great cognitive, behavioral, and then sort of more distal practices and package them together, things like mindfulness-based stress reduction, adaptation practices, something that's been used with physician groups and others. Those can all be things that we can really educate others about and also practice ourselves as we sort of build resilient coping strategies. Peer support is really the other sort of kind of component that I would still classify sort of at the sort of eye level. And I would sort of pause here and say, what do you already have in place that resembles peer support? I think when we think of peer support, we think of sort of one individual helping another who's sort of on an equal plane or has shared experience, but this can look very different. So I would argue that a form of peer support can occur in a morning huddle at the hospital or at the clinic level. But it can also be a sort of formal paired peer support program. It can be groups, it can be one-on-one, right? So it can take all these different formats depending on how we choose to define it. And it's really more about the experience of support. I think that really defines it. But I've actually studied this quite a bit, and I've talked to healthcare leaders around the country in really large systems and small, where they're trying to really implement peer support strategies. And there's different opinions about whether it should be formal or informal, something you sign up for that's kind of a closed group or pairing versus open. Does it matter if it's in person or should it be virtual? Should it be anonymous? Should I sort of know who you are? Should I be getting peer support from other psychologists? Could it be mixed? Could it be me? Could it be the physician, the nurse, the MA, and others? Or maybe should it be really focused on our problem or sort of our special interest? Actually, one of the largest peer support groups for healthcare providers in the world. I had the pleasure of speaking with their founder, the Physician Mom Group, recently. They've got just about 1 million people who are enrolled in these programs. And it's free, and you can look it up yourselves. But this started as physician moms who kind of noticed that they were going through stressful things that were pretty unique to their circumstances, and not a lot of people understood. And so they were getting together. Now it's open to physician dads, non-physicians, non-moms or non-dads. It's really grown, but there's different ways to approach it. The key element, I would say, is safety, safety, safety. Your experience of psychological safety, of knowing that your credentials, your profession won't be at risk in sharing and engaging. Yes, it needs to be sensitive to individual preferences. It certainly needs to be perceived as available, but that safety is really the key. So if we sort of break down all these different strategies, there's been some great review studies like what I've cited here, where we sort of say, well, which intervention is best? Holy cow, psychologists, I don't even want to say this out loud, but it depends, right? So it really does depend. And there's not a lot of really, really good data, even as of this year, that sort of says this is the one intervention you should use at the individual or sort of the peer level. These are sort of being deployed live as we go, although there's research from years ago too, but we don't use the same kind of rigorous standards. So really, it does kind of break down to what works at your organization. But can we use our knowledge of these things as rehabilitation psychologists and others to really drive these sorts of changes? Can we bring that into also thinking about where external resources may be needed? And we know those of us who've worked in VA and Department of Defense and others, combat vets, the actual proportion of PTSD and other forms of trauma is actually not always explicitly high, at least at a diagnosable level. And so in this circumstance as well, we suspect that not everyone will come out with sort of a pure form of diagnosable trauma. However, we do need to account that, some of us are certainly coming out very injured from the care that we're providing right now. So using our awareness as psychologists and moving into leadership roles, when it comes to common sense practices that aren't always in place, things like credentialing and licensure, right? If I have to worry about disclosing my help seeking, my mental health treatment, for example, when I'm going through the credentialing process of my hospital, that's going to be a big barrier. If I'm sort of being labeled as this, not just a hero, but a superhero by the public, by my leadership in my hospital, that's going to be an impediment to feeling like it's okay to get help, right? So there, as psychologists, I think we're intimately familiar with these. And fortunately, other organizations, folks like Joint Commission, who normally I sort of associate with my own anxiety, have really been coming out in support of this and saying, look, it shouldn't be whether it's credentialing or licensure or whatever. The question shouldn't be, have you ever gotten treatment before? It should be, are you able to do your job now as it stands? And we need to reduce those barriers. But those are the kinds of perspectives that we as psychologists bring. So I'm going to turn it back over to Deepa here and kind of thinking about how do we sort of move from the eye level to other levels, but really kind of accounting for it. We have to first make sure, just as we would as psychologists, that we're not doing any sort of harm here, that we're not using bad intervention, certainly, and that hopefully, we're actually creating something good in the process with our knowledge.
Yeah, so let's move to team functioning then. And I really like this quote as well. Teams which display the ability to either thrive under high liability, so you see that word again with safety, situations, improvise and adapt to significant change or stress, or simply recover from a negative experience are less likely to experience the potentially damaging effects of threatening situations, right? So we see those factors of resiliency come into play again. And when you think about good team functioning, this is a wonderful article by Nancaro et al. 2013. And I know that other individuals are aware or have used this article. I've seen it presented at Rehab Psych, but within our team, we've used this a lot, actually. We've used it as a tangible qualitative resource in that we've rated our team on these various characteristics. We've thought about ways to improve certain areas that we rated ourselves low on, look into empirically supported interventions that would help team functioning in certain areas, and then re-rated ourselves and really use this as a framework to guide our interdisciplinary team functioning. The article does refer to both interdisciplinary and multidisciplinary functioning, as well as other team functioning as well too. So it's applicable probably to many of the settings that we're working in. But when we think about all of these factors, and then we're thinking about COVID-19 and the impacts that the pandemic has had on good team functioning, you can probably imagine that it has impacted the majority of these key characteristics of good team functioning. And a couple of the factors that I didn't initially appreciate that it probably has also affected, which I haven't marked off yet, but appropriate skill mix and individual characteristics are likely affected as well. You know, if you think about your team and how it has changed in the past now almost a year since the pandemic has been upon us, there are probably a number of teams that have changed a lot. Either there are people that have left for various reasons. There are new team members that are part of the team. Maybe you've never seen them face to face. You don't know who they are, what their skills really are, their strengths and weaknesses on the team, how they really impact the team culture. There's been a lot of changes to teams, some that might not seem very overt, but all of these factors have been in fact been infected by COVID-19 in effect. And so when we look at resiliency and these core factors of resiliency and how they relate to team functioning, now we can see, you know, a lot of these factors individually, we see that those factors are important for resiliency. They are also important for team resiliency, but I think it's important to note that individual resiliency does not equate to team resiliency. So you can have really resilient individuals, wonderful, great people on your team. And it doesn't mean that you have a resilient team that can bounce back from a stressor, right? So at the team level, there's other factors that take into account these other factors from resiliency that I have up, but it's a little bit different in that there's a collective factor in it as well, right? Collective efficacy, this unified creativity or problem solving, a cohesion amongst the team members, social support, not just individually, which Andrew talked about, but also within the team of providers as well, and how they support each other to create this climate of trust. And so teams do have the capacity to positively adapt to various stressors, but it's through their collective interactions rather than the individuals being resilient themselves. And so this is a really great article as well. And I encourage you, if you're looking at how to improve team functioning or team resiliency, this Bowers et al. Article from 2017 goes through and looks at, from various levels of the system, what factors might be significant and important in enhancing team resiliency. And so we'll just look through quickly, but at the individual level, some things that pop out: optimism, coping strategies, mental toughness. Maybe we think of that as individual resiliency. At the team level, what we talked about, that trust in individuals on your team. At an organizational level, there needs to be agility, that adaptation that we talked about as well. And what the process the outcome of that is, there's better stress management. There is better mental stimulation, mindfulness on the team. There might be better leadership on the team, better planning. And at an organizational level, there might be better transparency and information sharing. And then together we get those collective states of cohesion, of trust, of culture on the team, which is what leads to a resilient team. And having that resilient team leads to these better outcomes that you see on the page as well. And when you think about, on the next slide, if you think about who's really in charge of all of those factors, who has the ability to really empower individuals, that has the ability to cultivate optimism and hope, who knows how to maintain optimal functioning in the light of stressors and advocate for individuals, use MI strategies to motivate behavior changes and motivate thinking changes. That's you on the team. That's the rehab psychologist on the team that has the ability to do all of those things. And so really who's in charge is you, empowering you to make those changes. And on the next slide, there's some real strategies that we can use, right? So when we look back at the characteristics from Nan Carroll, Those 10 characteristics of good team functioning. There are many ways in which rehab psychologists already do this on an individual level and can really tweak that and apply it to a team level. So redefining the role of rehab psych on the team. I think it's really interesting, and Andrew and I had talked about this, how early in our careers, a lot of times it was told that working in a place that already has established psychology is really good. You have a good landing spot. People already know what you do. But maybe the opposite's actually better. Maybe it's better to pave your own path to create the narrative of what rehab psychology does and how you can be useful. So there aren't boundaries to what you do. And it can be challenging, but you get to create what that role looks like. But also, if the role is already established, making sure you're doing in-services, talking about what you do or what else you can do that might be different from other psychologists on the team. Being a team leader, again, not stepping on anyone's toes, but making sure you have a vocal role in the team. I've also had the pleasure of training on teams where rehab neuropsychologists were the leaders. So giving yourself that voice, that you do know all the dynamics on the team and you are really the expert at pulling together all the information to come up with the best treatment plans, the best team dynamics. You are the person that has the ability to do that. Making sure that there's regular meetings, whether that's team rounds or huddles, but also communicating barriers to team care. And also talking about the strengths of your team, giving out verbal accolades, those bolstering those positive factors on the team is something that rehab psychologists know really well how to do. All of this can help reinforce trust, team efficacy, clarity of the goals. I also think really important is adapting things that are really core to team functioning, right? Being housed in a same clinic. We used to probably socialize a lot more, have lunches together, stop by each other's offices, which isn't happening anymore. And rehab psychologists are really good at adapting strategies or current levels of functioning and how to adapt them in the face of a stressor or a change in functioning. So within my team, we do virtual lunches. We are, our regular socializing events, holiday parties, we've done virtually as well. So we still have access to that same feeling that the socialization will give us, but it's just a little bit different. And we can really help our team adapt to those changes as well. If possible, and Andrew's going to go into a little bit more about organizational support as well, but having a working group that really helps enhance the team dynamics as well can be useful. And so rehab psychology really taking the lead. And I want to acknowledge that basically nothing that Andrew and I are saying is new. All of this is very well established in the literature and in the field, but sometimes it helps to have a reminder. And so I purposely put quotes from much older articles from 13, 20, 30 years ago or more that our rehab elders have been telling us, and it would behoove us to listen to. So rehab psychologists using their training to promote proactive leadership in multidisciplinary teams. We are uniquely poised to provide proactive leadership. We have a unique constellation of competencies that are well matched to healthcare executive leadership roles. We're best suited for roles in research, treatment planning, development, and administration. We have an array of skills that are needed in organized delivery systems, and we're uniquely prepared to function as clinicians and managers in organized systems. And lastly, from Wegner, I took this a little bit out of context, Steve, in that you were talking more about establishing the training competencies for rehab psychology, but I think it's good to go back to how do rehab psychologists define their area of competence and our area of practice, and we have the ability to do that. And we're hoping that we can empower you to do that on a much bigger scale at the organization. So I'm going to pass it on to Andrew for that.
Thanks, Deepa. And I think, that sort of psychologists and rehab psychologists specifically as leaders really is where it's at. And so when we think about, moving from the individual to the team and now to the organizational level, all spanning resiliency, and I think, this is a great example where the core strategies that psychologists we are expert in really come into play. And I've worked with organizations all over the country, and invariably the ones that are not necessarily as individuals, but as systems really suffering and struggling the most right now are those that are inflexible, those that are sort of cracking as needs and priorities are shifting very quickly, whether it's in staff needs or to telehealth or whatever. Those who are inflexible are invariably those who crack. So one area where we can really deploy our skills, our know-how, is really in moving from sort of that like cognitive and psychological flexibility to also talking about organizational flexibility. I sort of think of the organization as like the last boss in the game. It's something that as sort of behavioral health people, we tend to not always want to deal with. We like kind of doing our change work with our patients, and of course, some of us move into leadership roles. But I would argue, as Deepa has, that there is opportunity here, and we can use our principles and our skills to make change at this level as well, especially around flexibility. So, what are some examples of this? Well, I'd say like put on your sort of clinical hats and think about these key areas. So looking at communication in general, like what might you advise to your patients who are struggling with communication, who are struggling around uncertainty, who need that sense of safety around trying to seek emotional support? How might we sort of deploy our psychological principles and theories when it comes to policies that sort of govern our organizations, to standards around productivity, documentation, other things? These are all the areas of inflexibility that are really undermining the resiliency of organizations where we practice right now. So if we sort of flip the tables, and I'd encourage you to sort of share them out here, but some ideas would be maybe for communication, it looks like the same thing we'd advise those that are going through a rehabilitative process, right? Frequency, repetition, being clear, communicating often and clearly, and bi-directional communication, right? So that's giving feedback and receiving feedback as a living reflexive system, doing what we can to minimize the experience of uncertainty or cope with its existence. When it comes to safety measures, there's so much controversy here, but again, as psychologists, I'd say, being realistic about what safety we can provide and trying to be as responsive to the situation and the needs of our staff as possible. We talked earlier about those different mechanisms for support, individualizing them. Psychologists were expert in the individual needs versus sort of those of a society. And so taking that perspective and really encouraging individualization is really important. The same way we'd encourage adaptive strategies for our patients, we should also encourage adaptable policies that are sort of reflexive to the situations when it comes to thinking about leave, time off, sort of where people take breaks. These are things that organizations kind of struggle to keep up with, and we can really rehabilitate. Thinking about productivity, can we sort of change our standards and sort of what we understand to be value at sort of the clinical level and sort of at the number counting level? That can be important too. Even using our understanding of trauma, both physical and emotional, in terms of how spaces are set up, not for just our patients, but ourselves, our own areas of practice. These are all principles that I think we can use as psychologists, as rehabilitation psychologists, to increase flexibility at the organizational level. I thought this Ragnatari quote is really great. The ability of an organization or a team to adapt to these short-term crises can foster long-term growth, right? And in a really dynamic way. So the same way that we would work with our patients and potentially our teams to not only grow in the presence of incredible stress and trauma, but to develop resiliency and actually to grow around and larger than these experiences, we should also be encouraging for our organizations as living, dynamic, sort of alive places where we're practicing and influencing and using these principles. So, we've got a couple of key takeaways here, and I think, throughout it, we'd sort of say like the I's have it, and the I being you, us in our roles here, being leaders, using our knowledge of the individual, of the team, and sort of the power of teams, and then of how we can create transformative, healthy, responsive organizations. Our hope is, that you kind of share in our experience of feeling empowered, of thinking about how can we use what we know, still provide the care we provide, but nurture healthy systems and healthy, larger strategies at the individual and all these other levels to really make change here. And again, creating these responsive teams. So sort of at all levels, but, I'd also bring back kind of where we started with, Dr. Chung, the palliative care ICU doc that we had heard her tweet at the beginning around resiliency. we reached out to her actually before this presentation and let her know that we were interested in using that, and she responded with this, which I thought was very compelling, and I'd like for us to end on, which is, thank you for your work and for raising awareness for burnout. We need more compassion, understanding, and kindness out here. This is in response to this information being shared at our conference today. So, I don't think we can say it any better than that. Whether it looks like the care that you're providing directly to your patients, whether it looks like how you're organizing and encouraging your teams, or how you are positioning yourself and your organizations to be human as organizations, to be resilient and thrive and grow through everything that's going on, and also to cry and just sort of be there when we need to. That's what's going to be transformative in these systems. And that's what we have the control to really do something about. So, as we move into the Q&A here, we'll encourage you to sort of think about this and think of, what's something that you can start doing, as we started with, when you leave today or tomorrow or next year. And then also, is there something that maybe you need support or help on? Is there something you need to investigate further? Do you have suggestions for us and for others here in this discussion? So you have our contact information here. Follow us on Twitter, email us. Let's keep this conversation going. Deepa, what sort of parting words do you have for folks?
So I'm really interested to just hear how other rehab psychologists have moved into leadership roles and how they've really leveraged the team to create changes within organizations. I have moved into a leadership role, but I'm interested in furthering that as well. So I want to hear real life experiences from other individuals and how they've done that as well, and share that amongst ourselves.
Great. All right, well, thanks everyone, and we look forward to chatting with you right now in the Q&A.
Thank you. Thank you.